Dr. Ochoa. Dr. Ochoa wears two hats, one as a basic scientist as well as a clinician. So he received his medical degree and internship from Columbia, Columbia, South America. Then he joined as a postdoctoral fellowship at University of Minnesota, Minneapolis. He subsequently did a residency at LSU Health Sciences, New Orleans, and also he was a clinical fellow at LSU Health Sciences. Then he went back to University of Minnesota as a faculty member, then joined the LSU Health Sciences as a pediatrician and a faculty member. He has been at LSU for quite some time, and he has been wearing two hats, as I said. On the basic side, he works on understanding mechanism of immune escape and immune suppression caused by myeloid-derived suppressor cells, and specifically the role of arginase in T cell function. So as a clinician, he is the founding father of the Stanley Scott Cancer Center, and he was the director since for the last 15 years. Last year he stepped down and he's now the deputy director of the center as well as the head of the oncology department. The unique thing about Dr. Ochoa is that he directs the Gulf South Minority Underserved NCORP, which is the only multi-institution program to offer clinical trials to patients throughout Louisiana. And he currently enrolls about 1,500 to 1,600 patients a year. And most of them are 55% of the people enrolled in this program are African Americans. He has been publishing extensively, and he's well funded. Most recently, he received the Gulf South Clinical Trial Network, NCI Community Oncology Research Program. And he has a list, it's about 3-page list of grants that he has been funded over the years. And I'm not going to bore you with too many things. So today, Dr. Ochoa is going to talk about on the role of lipids in T cell modification in cancer. So without further delay, I call upon Dr. Ochoa to present his findings.
And I want to thank Alan for that great presentation, which was a great segue to what we're going to. I'm a clinician, and clinicians, we are much simpler in our way of thinking problems through. I thoroughly enjoy the multi-omics approach, and I certainly hope to learn a ton about it. Eventually, there'll come a time when medicine will be able to incorporate the multi-omics approach that Dr. Tackett was talking about. And then we'll be able to make better combinations and better combined approaches to treatment. But today, I want to talk to you a little bit about regulation of lipids. If I can get this thing to, here we go. So I'll go ahead and again, thank you very much. And I'm going to try to accelerate the process here. So as I was saying, the work that I'm going to be talking about today is the work that's been done primarily by all of these young investigators in the laboratory and in the cancer center. When we talk about immunotherapy, of course, we're very excited because over the past 10 years, immunotherapy has come into its golden age. Finally, we've cracked through the codes of what makes the basic immune system work, and we've been able to make some major changes in what happens to our patients. But if you look at history, ever since even the ancient Egyptians, there are references to somehow triggering the immune system to achieve an anti-tumor response. As you see there, 2600 BC, there was recommendations of putting certain combinations of herbs and roots on tumors and making scars on the tumor so that they essentially would get infected and would trigger an immune response. As you can see throughout many of the different cultures and races throughout the world, similar approaches were used to treat lymph node tumors, lymphomas probably, with infections, and with specifically with erysipelas. Now, William Coley in the early 20th century was the one who really codified this whole process. And he demonstrated that if women who had breast cancer got infected with a certain type of streptococcus, then they would not only have prolonged survival times, but in many cases, the tumors would disappear. And so he thought that that was a product that was being produced by the infectious agent itself. The problem was that as he cleaned this whole process up, as he made it less infectious and less problematic for the patients, the effects of the anti-tumor effects were starting to get lost. So it took about 100 years for us to really start understanding what really was happening in that tumor microenvironment and how the immune system had to become programmed through a process of antigen release, antigen presentation, activation of the immune cells in the lymph nodes, eventually trafficking of those T cells to the tumor cells, and recognition of that antigen and killing of the antigen. But that was really a very simplistic approach to understanding what was really happening, as we all know today, because there was an enormous number of signals that would either activate the cells to develop their anti-tumor functions, as shown here in green, or a plethora of other signals that would block those T cells. And it's not that they would block the T cells because the tumors were smarter, but actually because the immune system itself has these inhibitory signals, so that every time we get stimulated by an antigen of some sort, we don't all become into a huge lymph node that is uncontrolled. And as a matter of fact, there are immunodeficiency diseases where patients have none of these regulatory systems, and they actually die of an over-response of the immune system. So we were able to understand these, and as Dr. Tackett mentioned earlier, many of the new immunotherapies that were developed over the last decade took advantage of that. And as we all know, inhibiting the PD-1 leads us to having these very obvious responses that are mediated by T cells. If you look at the tumor before treatment and after treatment, now it's full of T cells that are killing the tumor. And if you look at this, what is called a waterfall plot, the size of the tumor rapidly decreases in the majority of patients. And as a matter of fact, this is a patient with Merkel cell carcinoma, which is a virally driven tumor. And it is now the preferred form of treatment for Merkel cell carcinoma, where about 75% of those patients respond after the first treatment. Based on that same set of observations, and now really realizing that T cells can recognize mutated antigens on tumor cells, people like Carl June developed what is called CAR T cells, and Dr. Tackett mentioned them previously. So the question was, is there really room to improve? And as Alan said correctly, yes, there is. And there is, because the overall response rate to immunotherapy in general is about 30%. Now, that's 30% in patients who had no other form of treatment. Metastatic melanoma was a deadly disease 10 years ago. Many of the tumors that now respond, Merkel cell carcinoma, the survival of Merkel cell carcinoma patients was 6 months. 6 months with the best chemotherapies we had. And it's now those patients are passing 5 years and still surviving. So there is major progress. However, not everybody responds. There are associated toxicities with it. We are not clear yet what the long-term response is. We do know that patients who have complete responses, meaning all tumor disappears, have long-term responses, but partial responses have a mixed bag. And then the idea is that if the immune system really can work in treating existing tumors, how about if we can prevent them? Because we know in the field of oncology that prevention would be the ideal approach for cancer rather than treatment of existing tumors. And so the question is, okay, so what's the next frontier on this? And I'd like to suggest that one of the frontiers that we have on hand is really understanding what Dr. Tackett mentioned, that tumor microenvironment, because that interplay not only of signals that come from the tumor to all of the immune cells, T cells, myeloid cells, natural killer cells, et cetera, not only regulates how those immune cells work, but also because that tumor microenvironment presents a phenomenal metabolic challenge for the cells that arrive to that site. As Alan said, the tumor is consuming glucose at a phenomenal rate, at a huge rate, such that at the end of the day, they deplete glucose, they produce a lot of lactate, and they deplete oxygen, such that this environment is hypoxic, is acidic, and is hypoglycemic. And that represents a major challenge for the immune cells. Otto Warburg, who won the Nobel Prize in the 1930s, was the first person who really challenged this concept and started studying how the tumor microenvironment might be metabolically challenging. I'm not going to go into the details of the Warburg mechanisms because they're pretty complex, but suffice it to say that the tumor, whether it's in the presence or the absence of oxygen, is constantly consuming glucose. It doesn't produce a lot of ATP, but produces enough for it to continue to grow. But what it does is it does deplete this glucose from that environment. And why is this important for the immune system? It's important because many investigators, in this particular case, Erica Pierce, have shown that if you take a T cell in a steady state, it's not using much nutrients, it's just basically holding its own glycolytic function. But once you activate it with antigen, it rapidly increases its glycolysis and its glycolytic rate goes rapidly up. The effector cells and the T cells are highly glycolytic. Once they've done their job, they go back into a steady state, resting state, and they increase their mitochondria, start using a little bit of fatty acids, and decrease their glucose function. So if they come into an environment that has no glucose, that is glucose depleted, then their ability to function is significantly decreased. The same thing happens with myeloid cells. So now in this case, David Pierce, who is Erica Pierce's husband, has done these very interesting studies in parasitic diseases. And he showed that myeloid cells, specifically macrophages, normally use glucose in their normal functions. However, if the animals are infected by parasites, they switch, remember, from a macrophage M1 type macrophage to an M2 type macrophage, and they switch from using glucose to using fatty acids. Fatty acids are internalized into the cells through different receptors. And when they come to the mitochondria, there's an enzyme called CPT1, which we will hear about in some other slides that I have ahead of this. And this is the rate limiting step for the incorporation of fatty acids into the respiratory chain for the production of ATP. So the question that we have had over many years is, what do myeloid cells do in tumors? Because everybody's talking about myeloid cells as they were bad actors. They are immunosuppressive cells. They block, they are tumor-associated macrophages, they're myeloid-derived suppressor cells. And the reality is they're neither. What they are is they are tissue repair cells. And as the tumor grows and damages tissues, all of the signals that get released during the tissue damage stimulate the activation of myeloid cells, and these myeloid cells come to the site of the tumor with a hope of trying to heal those tissues that are getting damaged. As a matter of fact, if you ask the surgeons, both surgeons of people as well as surgeons of pets, I'm sure, you'll ask them what is one of the difficult issues of doing surgery in cancer. One of the difficult issues is that there's an enormous amount of fibrosis, because what the myeloid cells are doing is they're stimulating fibroblasts to surround the sites of damage so that they can limit the spread of these malignant cells. And that causes a massive fibrosis, which might help in other conditions, but not in cancer, but because cancer is not the wound, is the wound that never heals. And so it does not help much. So in those chronic conditions such as cancer, what happens? That these cells become immunosuppressive, because the last thing you want when you're trying to heal a tissue is you don't want an angry T cell spilling out cytokines and creating all kinds of inflammatory responses. You want to stop them from doing that while you start healing the tissues. And so they become immunosuppressive, and they have different ways of doing this. They express arginase 1, and that arginase 1 consumes arginine in the tumor microenvironment. And that the T cells that come and get stimulated in an arginine depleted microenvironment stop their signaling. They don't die, they just sit there, but they cannot be activated in the absence of arginine. They also produce nitric oxide, and nitric oxide can actually kill cells. And they produce peroxynitrates that do the same thing. So what happens with lipids? Let's go back to the subject of lipids and the tumor microenvironment. So about 2010, Dmitry Gavrilovich, one of the leaders in the world of myeloid-derived suppressor cells, showed that if he looked at the MDSCs that were in the tumor, they were full of lipid droplets. And as tumors continued to grow over time, the amount of lipid was accumulating in those cells. So a group of postdocs in my laboratory several years ago decided to ask the question, well, what happens to these myeloid-derived suppressor cells? So they took myeloid-derived suppressor cells from a normal mouse. They have a few, not many, but a few in the spleen. They got some from the tumor-bearing mouse, also from the spleen, but also from the tumor, the MDSCs that were infiltrating the tumor, or the T MDSCs. As you can see, they are significantly many more. And so they asked the question, well, if myeloid cells normally use glucose, what are these cells using? And obviously they were using lipids. You can see the lipid uptake of these myeloid-derived suppressor cells that were in the tumor. And as you can see, all of the types of myeloid-derived suppressor cells, LY6C and LY6G, meaning the granulocytic cells and the monocytic cells, these are just morphology markers. They all incorporated lipids, while the myeloid-derived suppressor cells that were in the spleen of the tumor-bearing mouse or the normal control did not. So what this was telling us was that something in that tumor microenvironment was suddenly switching that MDSC from using glucose to now using lipids. And at the same time, as we saw before, they had those cells in the tumor had turned on arginase, nitric oxide production, and peroxynitrites. What else happened? Those cells were now rapidly consuming oxygen, as seen here in this seahorse test. Oxygen consumption rate went way up in these tumor-associated MDSCs, but also the production or the metabolism of glucose. So this simply said those cells were metabolically very active. If you look at the ratio, however, of oxygen consumption rate, which is an indirect measure of lipid metabolism or fatty acid metabolism, that was the most predominant one as compared to the production of glucose. Not only did they incorporate lipids, but they were also metabolizing the lipids. As I said before, they are now expressing CPT1, which is that enzyme that is the rate limiting step of lipids going into the mitochondria. And if you look at the different enzymes, not all shown here, but a couple more, you see that even they have a high expression of PGC1, which is the last enzyme in that whole pathway. And these cells were immunosuppressive. So what happens if we block fatty acid oxidation in these cells? So what we did was we took mice and treated them with a drug called atomoxir. Atomoxir is an inhibitor of CPT1 that was developed for fibrotic diseases. It was tested in patients, but unfortunately in patients, after a couple of months of giving atomoxir, even though the toxicity was not significant, their liver enzymes started coming up. And so they had to stop the development of this drug. But we could test it at least for what we needed to do. And what you see is that the first thing that happens is that the fatty acid if you take out the MDSCs out of these animals that are receiving atomoxir, the fatty acid uptake in those MDSCs goes down. The energy being produced, the ATP being produced goes down. The type of MDSCs in the tumor do not change, but you do see a slight reduction in the production of arginase, nitrites, and nitrosylation. The more interesting thing was that if we gave the atomoxir to mice that had 3-allele lung carcinoma after the tumor had developed for 4 or 5 days, you saw a significant delay in the growth of the tumor in mice receiving this drug. And this delay was mediated by T cells, because if you depleted the T cells in the mice receiving atomoxir, you lost that anti-tumor effect, either depleting CD4s or depleting CD8s. And if you combine this with an adoptive cellular therapy with a specific T cell that was directed against the tumor, you would also see a combined effect of atomoxir with adoptive cellular therapy. And what we found was that the cause, or a part of what was happening, was that if we just gave the cells alone, we had about a 1% of the cells infiltrating the tumor were those antigen-specific T cells. But if we added that atomoxir, now we had about 10%, so 10-fold increase in the number of cells that were now infiltrating the tumor. And if we combined it with chemotherapy, in this case cyclophosphamide, the effect was even more significant. More importantly, I think, was the fact that this same phenomena was happening in patients. So if we took a sample of colon carcinoma in this case, we looked for the numbers of CD66B, which is the marker for myeloid-derived suppressor cells in humans, and for the expression of CPT1, which is that enzyme that I mentioned before. And if you merge these images, you can see that it is the MDSCs that are expressing that enzyme. So the conclusion for this very first part was that these myeloid-derived suppressor cells do have an increase in lipid uptake when they enter that tumor microenvironment, and this may be responsible for the induction of their immunosuppressive functions. So all of that is great. Unfortunately, atomoxir is not something we cannot use, and so we decided to look at a slightly different approach. And again, a group of postdocs, graduate student, Faithan Philbrook, and a postdoc, Matthew Dean, took on this project of studying lipid receptors and the anti-tumor responses. Because obviously, if these cells were uptaking lipids, what was the receptor they were using? Could we block that receptor instead of having to block the metabolism of the lipids? And we had the help of Dr. Paulo Rodriguez, who's now the chair of immunology at the Moffitt Cancer Center and who was my star postdoc many years ago, but he is fortunately way past any of my expectations and achievements. So I'm very happy that we still have a very good collaboration. So let me briefly set you up for this conversation, because I think this is where this becomes even more interesting, but especially based on what Alan was talking about. So we tested the traditional receptor that everybody talks about, CD36, knocked it out on myeloid cells, and actually had CD36 knockout mice, and nothing much happened. Nothing much happened. So CD36 was not the receptor that we would be very excited about. So Faith and Matthew decided, let's start looking at other receptors. So traditionally, lipid receptors are divided into two categories depending on the size of lipid that they bind. So there's the small chain fatty acid receptors, and they are called GPR 41 and 43, and they bind lipids up to about 6 carbon length. Then there's a long chain fatty acid receptors that they bind carbons from 14 carbons on, and these are GPR 40 and GPR 120. And then there's an orphan receptor that is called GPR 84, and it binds medium chain fatty acid receptors, which is anywhere between 6 and 12 or 6 and 14. And they all have a complex signaling mechanism. Now, the interesting thing is that this medium chain orphan fatty acid receptor, it's orphan because the structure doesn't quite match any of the other ones, is expressed predominantly on immune cells, and it can be up or down modulated depending on the type of signal that the immune system receives. It is also expressed in fibroblasts, and so there were some groups that were studying fibrotic diseases like idiopathic pulmonary fibrosis, like liver problems, and they were trying to use this. And so they developed a series of either agonists or antagonists. The agonist that binds this receptor is DL175, and the antagonist is GLPG1205. So just keep those two in mind, because we will talk about it quite a bit. So the hypothesis here was, or the idea was, if we stimulate this receptor either with an agonist or an antagonist, is it going to change the properties of T cells, myeloid-derived suppressor cells, and eventually change the effect in vivo? So the first thing we did was we looked at the expression of GPR84. And what we found, and this is in MDSCs, we found that in the naive MDSCs that gets pulled fresh out of the bone marrow, there's very little expression. If you then stimulate it with the cytokines that lead to the development of MDSC functions, then they start expressing the receptor, and GLPG1205 doesn't do much. DL175 maybe decreases it a little bit, but not significantly enough. What it does, however, is dramatically change the function of those cells. So if you grow this MDSCs, as I said before, they express arginase and iNOS. But if you add the antagonist to the GPR84, you decrease both iNOS and especially arginase. But if you add DL175, you rapidly increase both. So it's black and white, which is very interesting by just one receptor. And this is the quantitation of what I'm just showing you here. If one then tests their immunosuppressive capacity, then one sees that the control MDSCs are able to shut down a T cell from 100% proliferation to about 40%. If you stimulate those MDSCs with the antagonist, they lose some of their immunosuppressive function. Interestingly, and I'll say something about this a little bit, I won't delve too much into it, the agonist does the same thing, but the agonist probably does the same thing because it shuts down a lot of the energetic processes in these cells. And even though they're now expressing high levels of arginase, they cannot carry out their function. So we decided to focus on this antagonist because this antagonist was decreasing the immunosuppressive function. But we also asked the question, what happens in T cells? Do T cells go, is there a similar response in T cells? And here, very similar to what we saw before, naive T cells express very low GPR84. But if you stimulate them with antigen, in this case, anti-CD3 and anti-CD28, they rapidly increase the expression of GPRD4 that is not changed by either the agonist or the antagonist. But their functions, again, changes dramatically. If you look at the proliferation of CD8 T cells that get stimulated with antigen plus the antagonist, they rapidly increase their proliferation. And if you instead add the agonist, the DL175, it rapidly decreases their proliferation. I think more importantly for us in terms of cytotoxic function is the expression of cytolytic proteins. And as you can see here, the addition of the antagonist rapidly increases both perforin and granzyme B, which are the primary lytic proteins that are used by T cells to kill tumor cells and to kill any cell. And this is the quantitation of this phenomenon. Again, the agonist decreases both of them. So the question was, does this really change their cytotoxic function? So we tested cytotoxic function in vitro. And as you can see here, this is our control cell. And this is an antigen-specific model. This is against ovalbumin. So this is OT1 T cells that are directed against the epitopes presented by ovalbumin. And as you can see, the control cells kill about 60% of the tumors at a 3-to-1 ratio. But if you add the antagonist GLPG1205, this goes up significantly to about 80%. And if you add the agonist, it decreases. So in vitro so far, the same thing was happening. It also changed a multiplicity of things in these cells, which I thought was very interesting. The first one was that it increased maturation markers, CD69, CD25, which is the beta chain of the IL-2 receptor, and interferon gamma production. It also increased the expression of checkpoints, which is a marker, again, of activation and maturation, CTLA4, LAG3, and PD-1, which suggests to us that maybe a combination of this type of stimulation with anti-PD-1 might protect these cells from the immunosuppressive effect of the tumor microenvironment. In addition, they produced just about every inflammatory cytokine that we tested. I'm just showing you 3 of them here, but IL-2, IL-15, TNF-alpha, and even IL-12 were increasingly produced by these T cells stimulated with the antagonist. And they moved from being naive cells, so there were less naive cells when you stimulated them with the antagonist, and there were more effector memory T cells. So they were moving them into a setting where these cells could theoretically at least be more effective. Now, when you're using a small molecule like the ones we were using, GLPG1205 or a DL175, you can have a lot of off-target effects. So to really demonstrate this was something related to GPRD4, what we did was we took antigen-specific T cells from a mouse that recognizes melanoma, a P-mel mouse, and we deleted through CRISPR the expression of GPRD4. And as you can see here, the mice that lost GPRD4 were, again, the T cells were more cytotoxic than the standard T cells from the same mouse. As mentioned before, these T cells were now much more metabolically active. So they had a higher consumption of oxygen and a higher use of glucose. What does that mean? Why was that important? It means that they're now using both lipids and glucose. And if one looks at the T cells that are most metabolically fit, it is a combination of use of both oxygen, both lipids and glucose to produce ATP. Because if you just use one, like glucose, then you burn out and move into exhaustion very quickly. But if you can use both, then you're able to face that tumor microenvironment and carry out your functions more effectively. In fact, if one quantifies the ATP that is being produced by those T cells, as you can see here, the T cells that are stimulated with the antagonist produce a lot more ATP from glycolysis, but they're also producing more ATP from fatty acid oxidation. And if one places them into this energetic map, they are much more energetically fit than the regular T cell. So if they're using glucose, are they turning on the glycolytic pathway? And the answer is yes. This is the antagonist, and you see that all of the enzymes participating in the pathway of glycolysis are upregulated, while if you use the agonist, they are downregulated. So again, sort of black and white. We then did a series of studies where we did single-cell RNA-seq with these T cells to see what was really happening in them. The cells that, and I'll jump this, but I think the most important part to this is that if one stimulated these cells with the antagonist, you can see here that the early effector cell, the proportion of early effector cell, which in the control cells is about 28%, jumps to about 41%, while the naive cells that are 26% in the controls decreases to 16%. And that is with the antagonist. But if you look at the agonist, it maintains and even increases the number of naive cells. And we believe that is in part some of the explanations of their lack of function. With the RNA-seq, we looked at the whole variety of different pathways. We obviously wanted to look at the metabolism pathways that we thought were turned on. As you can see, the glucose metabolism, the cells that were stimulated with the antagonist here in this middle column, where all of the glucose metabolism genes were turned on essentially, which was also the same case in lipid metabolism, fatty acid metabolism, and the cytotoxic function. So RNA-seq confirmed what we were seeing in terms of functional assays. So now the question is, does this make any difference at all in terms of treatment? And the answer is yes. So to do these experiments, what we did was we took animals that had, in this case, an ovalbumin expressing tumor, and we used T cells from an OT1 transgenic mouse that recognizes a specific peptide on that ovalbumin. Peptide is called synfecal. We took those cells, we stimulated them in vitro with antigen plus the antagonist, and injected those into mice that had had the ovalbumin expressing B16 melanoma for 7 days, and treated them with nothing else, just followed them over time. And as you can see here, this is the average for all the mice. The mice that were sham treated essentially didn't receive anything. The tumor is growing. The animals that received the OT1 cells that were stimulated with antigen alone had a significant reduction in tumor size. But the combination of antigen stimulation of those T cells plus the antagonist for the GPRD4 had the best therapeutic approach. And this is the spider plots of each one of those individual mice. And as you can see, the animals that received the T cells stimulated with the GPRD4 antagonist plus antigen had the best anti-tumor response. Similar to what we had seen before when we were studying the atomoxer molecule, what we're seeing here is a rapid increase in the number of antigen-specific T cells infiltrating the tumor. Here are the 20% of the cells have autofluorescence in the sham-treated mice, 27% in the animals that were receiving the OT1 T cells, but that were just stimulated with antigen. But if they were stimulated with antigen plus the antagonist, then about 54% of the cells were the tumor-specific cells, antigen-specific cells that were now infiltrating the tumor. But OT1 and ovalbumin is a model that is not very liked by reviewers because it doesn't present a real tumor antigen. So we decided to use B16 melanoma and treated it with CD8 T cells that were coming from a female mouse, is a transgenic mouse whose T cells recognize the GP100 antigen on those melanoma cells. And as we saw before with the OT1s, the T cells that were stimulated with the antigen plus the GPR84 antagonist had the best anti-tumor response of all. We then decided to ask a very simple question. If the GPR84 antagonist is so effective in vitro, will it be effective in vivo? And the short answer to that was that in a tumor-bearing mouse, it didn't work. We don't exactly know why. We're starting to figure that out. If it's that we are not able to achieve the right concentration, if the drug is being metabolized too quickly and then we don't have an effect, or is it because the receptor is modulated somehow in that tumor microenvironment such that even if we give them an antagonist, there's no receptor to antagonize. So we don't know the answer to that yet. We're in the process of working that out. What we did find out, however, is that if we gave the drug to an animal that did not have tumor, so in a vaccination model, then we had a very interesting effect. We saw that, and so let me show you what we have here. We just cut to the chase here for a second. Here. So if we took an animal and started giving them tumor cells and then gave them a low-dose cyclophosphamide, transferred some cells, and then what we did was we vaccinated the animal at that same time, just with a vaccine alone, and gave the GPR84 antagonist orally, then we were able to prime the system and induce an anti-tumor effect that was not as effective as adoptively transferred cells, but clearly showing that you did have some effect, suggesting that we might be able to manipulate this microenvironment, but we need to really find out what is going on with those receptors and with the type with the concentrations of the drug that we're using. So I think what this tells us is that, and this is where I'd like to end and open it up for discussion, is that understanding the tumor microenvironment, the metabolism of the tumor microenvironment may help us identify novel approaches that will allow us, our T cells, to become much more effective, either through adoptive cellular transfer or through priming of the T cells in the tumor microenvironment. We know now that lipids and lipid receptors not only regulate myeloid-derived suppressor cells, but as you can see here, clearly T cells. Now, the functions and how these receptors work is unclear. Some of these are GPCR receptors that are stimulatory, but GPR84 is an inhibitory receptor. And so the targets are different and the mechanisms are different. And so we're hoping to try to unravel that whole process quickly. We do believe, or I do believe, that therapies that combine metabolic regulation and metabolic protection of T cells, in addition to giving them a stimulatory signal by antigen of some sort, will certainly have a combined effect. We have preliminary data here from this animal model. GLPG1205 is a drug that was tested already all the way up to phase 2 trials in other diseases unrelated to cancer. And so we're hoping to use that drug now in a clinical trial where we can either stimulate CAR T cells prior to infusion, or we can use it in combination with CAR T cells infusion. And so that's where we are with that. And I will stop there and take some questions. Thank you.
Dr. Ochoa, I have one, if I may.
Yes.
Can you hear me? Absolutely beautiful work. Thank you so much. And obviously you've shown us an exquisite complementary effect on MDSCs and on the cells that you would imagine, the T cells that you'd imagine to eradicate, or at least act in concert to eradicate or attenuate tumor cells. What about Tregs? So you've looked at myeloid suppressors, and the natural question now would be, what about the regulatory cells of a lymphoid nature?
So that's a very interesting and important question, and I can't tell you yet because that's our ongoing experiment that Matthew Dean is carrying in the laboratories. As you know, the culture of the different types of Tregs is a finicky process, and he has just set up the different conditions for the Th17s, for the traditional Tregs, and for others, and is in the process of testing that. But I don't have the data, or we don't have data yet to say anything about it. But that is essentially, no question, one of the next questions we need to tackle.
And thank you. I was very impressed with your T-cell MDSC assays, and we've tried them in the dog, and they are a devil to get going in a reliable manner. Did you stratify PMN MDSCs and MMDSCs, or were they all MDSCs in the assays that you showed us?
So in the assays where we were testing the antagonist and the agonist for GPR84, it was all MDSCs. We did not separate G or M MDSCs. However, in most of our tumor models and in most of our patients, the majority of the cells that we isolate are G MDSCs that have the highest expression of arginase and inos.
Absolutely. No, thank you. Thanks.
What is it?
Are there intrinsic variations of the GPR84 level?
You know, it's an interesting.
Can you repeat the question?
Yes,
for the remote
yes.
audience?
The question from Wei Zhen was, are there intrinsic variations of GPR84 expression in different individuals? And we've looked for that, and there's not much in the literature about that. And she's asking, does obesity or diet change modify this? And the answer is, we don't know. We have a young faculty member that is working in collaboration with investigators at Pennington. They have done a very, very interesting study where they looked at myeloid-derived suppressor cells in obese patients before and after bariatric surgery. And what they found was that MDSCs were significantly increased prior to surgery, but following bariatric surgery, they decreased dramatically, which was very interesting because I thought with the surgical insult, they were going to increase. And actually what happened was that they fell dramatically. But this was not accompanied by a significant decline either in weight or in the lipid profile. So I'm not so sure what is driving that. And she is now looking at GPR84. Yes.
Right, Vishnu.
Yes.
How do you differentiate?
That's an excellent question, and I'm not so sure that we need to differentiate them because what I think is there are different stages of activation. Yes.
Can you repeat the question?
Oh, yes, of course.
Thank
So
you.
the question that was asked is, we use CD11B and GR1 as a marker for our MDSCs in mice. And these are similar markers that are expressed by neutrophils in these animals. And so the question was, how do we differentiate among them? And my answer is, not so sure that we need to differentiate them, because if we're looking at the cells that are in the tumor, they're generally MDSCs. They express high levels of arginase, much higher than the regular neutrophils. But I do think that they are simply different stages of activation, not different cell populations themselves. The MDSCs turn on arginase and inos when they enter that tumor microenvironment. And again, neutrophils are primarily a tissue repair cell. They're a first line of defense in infections, but in tissue damage, they're a first line of tissue repair. Actually, this was shown by a surgical group at the University of Connecticut, or maybe 1989, 1990, when they demonstrated that the first line of cells coming into a surgical wound were granulocytes, granulocytic cells. And after many years later, another group at the University of Pittsburgh showed that these cells would get to the wound and then switch to turn on arginase production and start the process of wound healing. So I think it's the same thing happening in tumors. Yes, go ahead.
My second question is about the TCR protein expression and signal sensitivity. Did you see a difference in between the individuals that are lean versus obese?
So again, that's similar to the question that Dr. Weishan was asking. We have not tested that. Question, very good question, but we have not tested that.
Good.
Yes. Oh, the effect of the antagonist on tumor cells. Yeah, there's no effect. If I do a clonogenic, we did clonogenic assays, obviously, to see if the antagonist might have an effect on the tumor cell itself. Is that the question you're asking? Okay, so the question was, does the antagonist or the agonist have an effect on the tumor cells? And the answer is no. When we did clonogenic assays, there was no difference in them. And as a matter of fact, when we gave the antagonist in vivo, we did not have much of a therapeutic effect. We had to stimulate the T cells in vitro with antigen plus the antagonist and then transfer them into mice. That was when we saw the effect. But that's an excellent question. Thank you.
Thank you. We love it. We love it.